So we are good to start in another 1 minute.
Okay, fine.
So it's sharp 6. So with all your due permission, can we begin?
Yeah, sure.
Thank you so much, sir. Good evening, everyone. This is Batul from IGCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. I would like to welcome the eminent speaker at our forum with great pleasure and honor, and he is none other than a very renowned anesthesiologist, Professor Dr. Nishant Kumar, sir. Sir is MBBS, DA, DNB, MNAMS, Professor at the Department of Anesthesiology at Lady Harding Medical College and Associated Hospitals. With Sir's wonderful inputs, we'll be taking a close look on today's topic, which is tips for USG guided blocks. Now, before moving on to today's session, let us have a brief look on what the topic says. Ultrasound-guided blocks have revolutionized regional anesthesia and pain management procedures by providing real-time imaging guidance for accurate needle placement. These techniques offer several advantages, including improved safety, precision, and patient comfort. To ensure successful and effective ultrasound-guided blocks, healthcare professionals should adhere to certain tips and best practices. We'll be learning more about the essential tips for performing ultrasound-guided blocks and enhancing proficiency and patient outcomes with Sir's wonderful input. So now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. Sir, over to you.
Thank you, Batul, for the kind introduction. So, good evening, everyone. Today, I'll be talking about tips and tricks for successful USG guided nerve blocks. Basically, we all know that USG is now omnipresent and sort of mandatory for successful blocks and to save us from medical legal issues. But yes, acquiring the image, knowing about the machine is essential. I won't be talking about any blocks, about any procedures. I'll be just talking about the tricks and the basics of how to achieve a good image and what and how to perform your procedures so that you achieve success most of the times. Now, when we talk of ultrasound, a few basics first. We have to understand the principles before we proceed on to any equipment, any procedure, any diagnostic equipment as well. Now, as we all know that ultrasound, as the name says, these are ultrasound waves. Human ears can hear up to 20 to 20 kilohertz of the frequency of the sound waves. Ultrasound is anything which the human ear cannot normally hear. So that is any sound with the frequency of more than 20 kilohertz is ultrasound. We all know bats, dolphins, and submarines use the very same principle of ultrasound waves to communicate with each other. And from there only, we have adapted this principle into medical ultrasound, which uses 1 to 15 megahertz of frequency of wavelengths for transmission of sound. And that is how the images are produced on the ultrasound. So how are these sound waves produced? Basically, what we do is we take a piezoelectric crystal. When electricity and pressure is passed through piezoelectric crystal, it emits ultrasound waves. Now, this ultrasound waves, it's a transmitter and a receiver as well. So it transmits the ultrasound waves, it goes and hits the tissue or the structure and is reflected to the ultrasound probe itself. So the probe is both a transmitter and a receiver, and based on the amount of the energy or the wavelength that is transmitted by the probe and the amount of waves returning to the probe, and a gray and white image is formed, and that is what we know that we see as an ultrasound image. So now naturally when the sound wave is passes through the tissues and it interacts with it, naturally there will be some amount of attenuation, skin and tissues. And now if you see this, the wave as it travels down further, it diminishes in its sharpness and velocity because it is passing through the tissue. There is some amount of absorption of the waves. So energy is dissipated. So less energy reaches the deeper structures. The reflection, it is the reflection from the tissue which produces the image. So more the reflection, better the image on the screen. There's some amount of scattering. So we know that when it hits an object, the rays get scattered into different directions, and therefore it is again a cause of attenuation. So all of these, basically absorption, reflection, scattering, and refraction, these lead to attenuation of waves. Now refraction is simply the passing of the sound wave through two different media. Now we have done this in school, that when we put a stick into a bowl of water, it appears bent. So similarly, refraction, when the sound wave passes through tissues of different densities, the sound waves also bend, and the image that we see on the monitor may not be exactly where the probe lies, but slightly at a different angle or a different position, right? So this is what is refraction. Now, to explain these in detail, attenuation. Now, as the distance travel increases, the strength of the wave decreases. So amplitude decreases with increasing depth. So high frequencies are used for superficial structures. They show a better resolution. And for deeper structures, we use lower frequencies because they have better penetration, but the image is a bit fuzzy. So if you recall, if you have used your ultrasound, the linear probe provides sharper images. It is a higher frequency. It is used for superficial structures. Even if you see the depth matrix, it is up to only 6 centimeters. Whereas when we use the abdominal or the curvilinear probe, the frequency is lower. It is 2 to 5 megahertz, and the frequency is lower, but the penetration is up to 30 centimeters. So you can see the deeper structures, but then again, the clarity is lost. Now, these things, the image quality can be compensated by adjusting the gain. The gain can be adjusted for the far or near field and the lateral field. So the time gain coefficient. If you see if we use the different probes, if you see, this is the 8 megahertz probe, you see the superficial structures. And now if you use a 10 megahertz probe, you can see the deeper structures better, but the clarity is not so well. Again, 12 megahertz, you can see much more deeper, but the clarity of the superficial structures is lost. So this is now how to set the gain. Now, if you see these three, as I've said earlier, now this you see the image is too grainy. You don't see the sciatic nerve quite well. But here, if you see, you can make out the different structures, the black and white images, and the nerve is quite prominent. And this is more or less a black image, so a reduced gain. So if you see this, the most optimal image is this. So this can be done by adjusting the near and the far gains and the time gain coefficient, right? Now, coming to reflection, we know that the sound waves travel in a straight line, right? So for a better image, for the clarity of the image, the best image will be when the structure lies absolutely perpendicular, when the sound waves are falling absolutely perpendicular to the tissue interface, so that the maximum light is reflected to the probe and a sharper image is formed. Now, if you see here, if the angle is less than 90 degrees, what will happen? The light goes like this, and some of the light is reflected, which is not captured by the probe, so the echo is weak. Similarly, if you see this for 90 degrees, now 90 degrees is the tissue surface, not the probe, right? So if the tissue interface is like this, even if the probe is at 90 degrees to the skin, the image may not be good. So basically, the idea is that you should have the probe at 90 degrees to the organ or the tissue interface that you're trying to visualize rather than the skin per se. So that is how it is. As I've said, more the reflection, whiter the image. Bone, tendon appear white. That is, white image is called a hyperechoic, and they show a shadowing effect. Black is usually fluid. Black image is usually due to absorption or transmission. Absorption means the entire sound waves which are coming are absorbed or transmitted or allowed to pass through. So black is usually fluid because they transmit the waves, and you can see the image below it. And bone is usually also appears black. So that is how you see the images, and this is called a hypoechoic. Anything which is lesser white is called hypoechoic, right? So hypo or hyper is with the background. That is how we see it. So these are the some of the terms that you'll be coming across. Now, if you see the shadowing, bone usually casts a shadow because the bone does not allow the sound waves to pass through it. If you see this is the pleura. Pleura, again, lung is an air-filled cavity. It does not allow the sound waves to pass through. Air is a poor conductor of sound. So, sound waves, ultrasound waves. So what you see is basically a repeated shadow of the pleural line, which forms like this, or which we call the A lines. So that is called the shadowing effect, right? Here we see the anterior complex, the transverse process. Again, because of the bone, it is seen as black. Now, what is anisotropy? Anisotropy is, it is seen in superficial musculoskeletal scans when we use a linear probe, and the reflection is based on angle of incidence, right? So if the approach of the needle or the probe is less than 90 degrees, then there's a loss of resolution of image. Now, if you see here, the angle is around 81 degrees, the image is not so good. As we keep on going towards 90 degrees, as the angle increases, 84 degrees, you see the structures here. Then you see the needle also. Needle is also appearing much better at 84 degrees, 87 degrees, and 90 degrees. So again, the same thing which I've been saying, that the probe has to be at 90 degrees to the tissue interface or the organ that you're going to visualize rather than the skin, so as to get the best and clear image. Okay. Now, the structures which have a radius which is less than the wavelength, they cause scattering. That means that scattering occurs in different direction, and only small portion of waves return. But however, this is useful to us because this also contributes to the Doppler effect, and it causes a speckled appearance of tissue. So the Doppler effect, because of the scattering, it shows the Doppler effect, and it is helpful in recognizing the movement of fluids, right? So we have the scatters in the fat, and the tissue planes are usually reflectors, so you get a sharp image. And then because this is fluid, it appears black, and when we put color, we see the Doppler, and because of the scattering, right? So if it's a reflector, the image goes back, and because of the scattering, the small surface, which is less than the wavelength, lambda of the wavelength, then it causes scattering. Okay, so if it's a large surface which is more than the wavelength of the sound wave that is being transmitted, we have a reflected image. And if we have a smaller surface, it will cause scattering, which won't be visible so clearly. As I said, for refraction, when the probe, the medium changes, so it causes bending of the waves. And again, as I said, irregular structures spread the sound waves. This is a refraction. A mirrored or a smooth surface will cause reflection. So that is high. And there is attenuation of the sound wave as they travel through different media. Now, what is edge shadowing? Edge shadowing is seen because of the refraction. Now, if you see here, this is a fluid filled cavity, a cyst. Now you see this is the edge shadowing. This is because of the refraction of the waves. And because of the fluid filled cavity, there is refraction of the sound waves, and it causes a edge shadowing, or a shadow which it shows that fluid is here also. But actually this is a shadow of a carotid artery. Here it is the shadow of the bladder, and here this thing is the shadow of the cyst, a fluid filled structure. And this is because of refraction of the sound wave that is being transmitted. Now, always remember, now these are the basics. So you have to know the basics of the ultrasound, how the images form, how the sound waves attenuates, how it reflects, how it refracts, how an image is formed. Now, always remember ultrasound is not a substitute to knowledge of anatomy. You have to know your anatomy to use ultrasound. Please remember, you just don't put the probe and keep on searching. You have to know your surface marking. You have to know the anatomy of the organ. You have to imagine a bit how the organ looks like in vitro and how it would look when you put in the probe. So you cannot do away with knowledge of anatomy. That is the must. Third is ergonomics. That is, you have to make yourself comfortable first, only then you'll acquire good images and the procedure would be successful. Ultimately, the entire success of a procedure depends on how well you acquire the images, right? And it is, again, if you get a good image, more detail you'll see and less complications and faster the procedure. So ergonomics, how you position yourself and the machine and the patient is very important. Now, if you see this patient, right, he's trying to give a block, needle is here, machine is there, he's all bent, the arms are getting tired. So what is happening is ultimately he'll have a backache, he'll have to look first at the monitor, then in what his hands are doing, and ultimately with a neck pain and a back pain and arm pain. Plus, he'll take a lot of time, the image won't be good, the patient will also not be comfortable. On the other hand, if you see this, back is straight, the elbows at right angle, the machine or the screen is right in front, and just by lowering your eyes, you can look at the monitor as well and at the side as well. So this is good ergonomics, right? Again, if you see this, here the machine is good, but while doing an echo, if you see the position of the patient, it's not good. So just by raising the height of the patient, making the patient closer to you, again, you can have a better ergonomic thing. If you're doing any other procedure, again, the back has to be straight, monitor in front of you with the side straight vision to the probe, and shoulder abduction should be less than 30 degrees. Elbow should be at 90 degrees. So this is the most comfortable position and good ergonomics. Another thing, you have to select the correct probe for the correct procedures for the correct tissue. We usually have these three probes: the linear probe, the curvilinear probe, and the phased array. So linear probe is used for general imaging, small parts, wrists, etc. Not used for cardiac, vascular. Yes, again, linear probe. Now we have a frequency from 5 Hertz to 12 Hertz. That is the usual frequency that we use. So it can be used for it is mainly used for superficial structures, but for some deeper structures, mid-deep structures, you can use this probe. Curvilinear or the convex probe, as it is called, or the abdominal probe, not used for cardiac, vascular, yes, mainly for deeper structures, and the penetration is very good for this. Endocavity probe, usually we don't use. Phased array probe is a specific probe with a low frequency, but with a higher frame rate, and it is used mainly for the cardiac assessment. Endocavity probe is a specialized T probe is a specialized endocavity probe, which you can use for cardiac and general imaging as well, but not for vascular. Now, how do you hold the transducer? Again, ergonomics. You have to rest your wrist. Otherwise, you'll end up with carpal tunnel syndrome. You say, okay, fine, I'm not working on the computer. I don't have a desk job. But you're doing a lot of ultrasound work. And if you're not handling the transducer properly, you'll end up with carpal tunnel and wrist pain. If you see this, if you hold it like this, the movement of the probe, the bottom of the probe, which is acquiring the image, is wobbly. If you use it like this, now you're holding the probe almost like a pen holding fashion. The wrist is straight and you have better control. Again, thumb-like, your wrist is going to restrict your movements. But here, if you see, your wrist is free and the probe is well balanced and well stabilized on the tissue interface. So you get better images. Orientation. Okay, now which is medial, which is lateral, which is superior, which is inferior, which is anterior, which is posterior. Again, anatomy. So all you have to do is spot the dot. So all the probes have an orientation marker. So as a rule of thumb, when you're doing a transverse procedure, the dot has to face towards the right of the patient. And if you're doing a longitudinal scan, the dot has to face towards the head of the patient, right? The only exception is when you're doing a cardiac ultrasonogram where the dot faces to the left of the patient when you're doing a transverse scan. So apart from that, mainly for blocks, it is the dot should either point towards up, towards the head of the patient, or towards the right side of the patient. That is the rule. Again, how should you go? When the needle is through the longitudinal path of the probe, this is called in plane. And when the needle is at 90 degrees to the probe, this is the probe, right? This is the probe, and the needle has 90 degrees to the beam of the probe. It is called out of plane. It is as simple as that. So if you see, if the needle is along the long axis of the probe, then it is in plane. If your needle direction is perpendicular to the long axis, then it is out of plane. Now, which hand to use? It is always better to use whenever you're doing a procedure, you use the non-dominant hand for transducer and your dominant for needle. Now, if you're a right-handed person, you train yourself to hold the probe with your left hand, acquire the images with your left hand, so that you can use the needle and give the block with your right hand, and vice versa for left hand. It is a natural tendency I can perform. I get better control over the needle and everything. But ultrasound, some people are ambidextrous. Now for the echo, for the cardiac ultrasound, naturally the radiologists use their right hand because they're dominant hand. But most of the times what they have to do is just acquire the images. And that's why they hold the probe in their dominant hand. But here for us, the most important thing is to do the procedure. So therefore, the non-dominant hand for the transducer and dominant one for the needle. Now, there are certain transducer movements which you can use to enhance your image. Otherwise, what you can do, what will happen is that you'll be in the right plane. The transducer would be there, but the image will not be good. So this can be understood by the mnemonic parts. I'll just go about it in detail. So if it is pressure. If you see this video, compression or pressure. If you see this, if you just simply compress your probe, the tissue compresses. Now, this is very useful when you're differentiating between an artery and vein because of their differential compressions. So, vein, artery, nerve, we know this, right? Differential compressibility. You can see the throbbing here, and you can see the vein being compressed by pressure, whereas the nerve remains unchanged, right? The second thing is alignment. Parts, remember parts. Alignment is rotation also. So how do we do this? Now, if you see this, this is a cross section of vein. Now, if we just turn it, this is out of plane or a transverse section, and when we turn it, we get a longitudinal section and an oblique section of the vessel or the tissue. So alignment of the probe with respect to the tissue will give you your longitudinal view, transverse view, or oblique view, which is achieved by rotation of the probe. Rocking. Now, rocking will help you enhance the image. Rocking is nothing but movement in the, you acquire the image, side by side rocking. So to see the side structures, and you have the rocking in the anteroposterior direction as well, so as to improve the image quality. Okay. Now tilting. So rocking is side by side and tilting is what I was coming to the later one. That is the in this plane and the other plane so as to get a sharper image. So it is basically rocking and tilting. So it is good for nerve visibility. If you see, just by tilting the probe anteriorly or posteriorly, we get a better image of the nerve. I'll just play this video again. So rocking is side to side movement and tilting is in the other plane. This is tilting. Now, if you see this, these are the nerves, nerve visibility. If you see, as we tilt the probe, the visibility improves or becomes or worsens. Next one is sliding. Now, sliding is when you want to see the structures and you want to follow the structures, or you want to see the structures in the vicinity which are anterior or posterior to it. So this is how you see the sliding movement. You see the entire length of the vessel, or you trace the vessel. And this is called as sliding. It can be done in both transverse and longitudinal methods, and sliding can be for lateral movement also, to see which structures are there. So what you do is you don't lose contact of the probe with the tissue, and you just slide in different directions and see what are the nearby structures, or to follow a particular structure. Okay, now we have to know how do the tissues appear normally on ultrasound. Each tissue has its own characteristic ultrasound appearance, and we have to identify and we have to know this tissue appearance. If you see this, fat is usually crisscross. These are the facial planes. You can see there is no organized structure. Bone, as I said, you'll see a hyperechoic boundary followed by a black structure. Muscle, usually you will see the fibrils in the cut section as we see. So you see well-arranged fibrils here. So anything which is crisscross is fat. Anything which is longitudinal or well-laid fibrils is muscle. Bone is usually hyperechoic, and you see a black shadow below the bone. Now, coming to nerve. Nerve, however, you can, there are different views of the nerves. Nerves you can see as a hyperechoic circle with the hyperechoic shadows inside. You can see totally hyperechoic from the surrounding structures, or you can see it as a bundle of nerves, as in plexus. Here you can see 3 nerves bounded by the fibrils, right? So this is how you see the nerves. Artery and the vein, again, hyperechoic structure filled with fluid. Normally, the vein is compressible, whereas artery is not, because arteries are thick-walled, and you can see the pulsations of the artery. But whenever in doubt, please put a Doppler and see which one is the artery and which one is the vein. Now, if you see here, this is the artery. It is pulsatile, and you can compress the vein, but the artery is retaining its structure. Okay, and you can later on see the pulsation also. Okay, so this is the artery, these are the veins. Pleura. Now, as I said, air is a bad conductor of ultrasound waves. You usually see pleura as a hyperechoic line, and you don't see anything below it but the shadow effect. Now, what you see is the sliding. Here you can see with the breathing movements, the lung is sliding. So that is a normal lung, and the line moves with the sliding, moves with the lungs. So this is how the pleura looks like. And if you see here, these are the ribs. You see the hyperechoic line and a black shadow beneath it. So this is the classical batwing appearance that you see on lung ultrasound. Fluid, as I said, hyperechoic shadow and black. So this is bladder, and you see the fluid here. Now, this can be confused with acoustic edge shadowing also. But if you see here, this is the bladder. Usually this is the edge shadowing, and this is what is the ascitic fluid. So, suprapupillary view of bladder. Now, for a block, naturally you have to have a needle. So how are the PNS and ultrasound needles different? Now, the ultrasound needles are echogenic needles. They have spectra echogenic, they have the Pajung echogenic tip, Bifron echogenic stimulus. So what it does, it provides extra surfaces for the sound waves to be reflected to the probe. So more the surfaces to reflect, better is the visibility of your needle. So echogenic needles are special needles, right? Okay. How to insert the needle, whether to insert it in plane or out of plane. That will depend on your structure and the availability of space. In plane is always better. So basically, if you see this, this is short access out of plane. Now, short access means transverse access of the tissue and you're going out of plane. If you see here that this is the needle. I'll just pause it. So first we see the short axis out of plane. Short axis, the axis means the tissue. Tissue is shown in the transverse, this one, and the plane refers to the direction of the needle with respect to the probe. Okay, so don't confuse the two. So short axis out of plane. Short axis means that the tissue that you're seeing is the transverse section of the tissue that you're seeing. Out of plane means the direction of the needle with relation to the probe. If you see this, the needle is perpendicular to the probe and it is usually seen as a dot. You can see this dot here, right? And when we move next, now the axis remains short only. That means the tissue that we see is transverse only, but the direction of the needle is now in plane. That is, it corresponds to the long axis of the probe. Now let us see how this appears. So if you see this in out of plane, the needle is just the tip of the needle is same, whereas when we take the needle in plane, you can see the entire shaft of the needle, and it is very important to visualize the tip and the entire path that the needle is taking, whatever structures the needle is traversing. So that is important to see, and that therefore it takes a bit of practice, but in plane is definitely better, whether it is in short axis or in long axis of the tissue, right? Okay, so we have already seen this. I'll just forward it. Now, this is the real time that you see. Okay, this is how your needle appears in this is how your needle appears in long axis. Okay. Okay. Now, we'll talk a bit more about ergonomics. That is the position of vantage. You have decided that you'll go in plane or out of plane. That is up to you. But the important thing is that the your needle should not be across the visual axis. Now, if you see here, you're standing here, the probe is like this, the vision is there, and your needle is entering 90 degrees to the entire this thing that you are seeing. Now, it has been shown that the success rate and complications are reduced when your vantage point is along the visual axis and hand position. So instead of doing this, this is the same axis that we are seeing, that if we do it like this, or I stand here and the machine stands here, that will be a better position rather than the needle entering 90 degrees to the student's body. So your needle should not enter at 90 degrees to your visual axis. It should always be in plane to your visual axis. So this is in plane. Now, if I go here like this, fine. This is also in plane. Now, rather than doing like this, I have to stand here and then enter from here. So this is important. So this is the vantage point. Okay. Now a bit about troubleshooting. Sometimes what happens is that area behind a weakly attenuating structure causes casts a strong acoustic echo. This usually occurs behind blood vessels, and it is often confused by a neural structure. We all know that vein, artery, nerves travel together. Now, if I remove this end here, this will appear as a nerve, but this is an acoustic shadow of the artery. So this may be mistaken as nerve, but actually the nerve lies here. So therein lies your knowledge of anatomy again. You should know what you're looking at, where the structure lies, and where to deposit your drug. So that is very important, and do not get mistaken by acoustic shadow. The needle also casts a shadow. Now just see this. Can you see this movement of the needle? And it is an acoustic shadow of the needle. So don't get confused. Now, when you're doing it in plane, if you see here, as the needle angle increases, the amount of waves which are being transmitted back to the, reflected back to the probe are decreasing, right? So it is always better not to have too much of an obtuse angle. Now, if you see here again, this is strong signal out of plane. Here is the needle shaft. Can you see this? This is the needle shaft, but it's a weak signal. The other thing is, how can we know it's a tissue displacement? Just by rocking the needle tip, we can know where our needle tip is. The tissue is displaced as we advance the needle. Okay. So that is another way of knowing where you are at. If you see here, this is where the needle tip is, roughly. Okay. Now this video shows at short axis out of plane, and this is tilting. Okay, this is a acoustic shadow that you see. This is in plane, needle in plane. And this is out of plane. Same needle which is out of plane. Steep angle, shallow angle, this is in plane. Now, if you see the shallow angle, the needle shaft is visible, but in steep angle, the shaft becomes, loses its clarity and only the tip is visible. So always try and keep a shallow angle. So this is what usually happens. Partial lineup of the needle and you lose the tip. Is this the tip? No. This is just the shaft. It has gone over and crossed over to the beam. Crossed through the beam. That is why the tip is not visible clearly. So it's a stair-step appearance that you will see. Okay. And always remember, complications can occur anytime. So you have to stop before you block, or you should check before you proceed for a block. Now, there are certain preparations that you have to do. Stop before you block. So you prepare your drugs and equipment. You do a scan first. You position the patient and clean the site. And just before you're introducing your needle, you stop and you say that I've completed my prep. Let's stop before you block. Assistant says, okay, let's stop before you block. You both check, mark, and consent check with the patient again. And if there's any confusion, please go back and check again, right? So if everything is fine, you give the block, immediately perform the nerve block and hand it back. So the thing is that you have to know that the site is okay. The procedure that you're doing is the same. The drug is all ready. You've already done the scan and patient is prepped up. So just 3 steps: prepare, stop, confirm, and then you perform the block. This reduces complications. And with that, I'd like to end my talk. Thank you. And I'm open to any questions that you may have. Thank you for a patient listening.
Thank you so much, sir. Thank you for such wonderful inputs upon the topic that you have shared today with all our viewers. We hope that this is definitely going to help them in their daily clinical practices.
Thank you.
So we have received few questions and I would like to put it across to you. The first question is, can we inject dexamethasone with peripheral nerve blocks?
Ideally, you should be using dexamethasone, which is preservative free. Yes, you can do it. Ideal way is to, if you're doing a study, you have to take an approval from Drug Control Government of India. Otherwise, you cannot proceed with the study, because you can use the drug which is approved by the drug controller through the route. Now, dexamethasone IV is available. We, in our setup, we have inquired everywhere in India. We could not find dexamethasone which is preservative free. So if you get dexamethasone preservative free, yes, you can use it. It has shown to enhance blocks, but then it is a good clinical practice. There are precedents, but then again, you have to, if you're doing a study, you have to take an approval for that.
Thank you so much, sir, for answering this question. We'll move to the next question. And the next question is, what is your opinion on blunted cannula styles as block needles for ultrasound guided nerve blocks?
See, in India, most of the times we do jugaad. Ultrasound needles are not easily available. They're costly. Blunted cannula, the reflective surface is not good. And again, if you make the needle blunt, then the injury and the tissue feel is not the same. What probably you can do is you can use the commercially available blunt needles, that is the PNS needles, but then again, the visibility is not so good on ultrasound.
Thank you so much, sir. Thank you for answering this question. We'll move to the next question. And the question is, can continuous catheter be placed in different site for postoperative analgesia? And are there any recommendations for this duration?
Postoperative catheters are being pulled ultrasound guidance. You have special catheters through needles or catheters over needles sets available. In fact, you have both PNS and ultrasound guided sets which are available. Plexus catheter sets, we are putting it. And yes, we can leave it for 2 to 3 days also. Normally, it depends how clean your wards are, how good your nursing staff is, how good your residents are, and how well you can take care of the site. So 3 to 5 days, yes, why not?
Thank you so much, sir, for answering this question. We'll move to the next question and the last question for today's session. So the question is, can we give obturator nerve block along with spinal anesthesia to a patient posted for TURBT excision?
It is recommended. Why not? It is why? Because the tumor is on the lateral wall of the bladder usually, and when they are excising it, the obturator nerve, because of the cautery, the obturator nerves there's transmission in the obturator nerve, and there is middle movement of the leg of the patient. So basically, it seems like that the patient is kicking the surgeon. So at times, being an anesthesiologist, you feel that the surgeon deserves it. That is, sorry, don't quote me on it on a lighter vein, but yes, why not? So it is commonly used for the purpose to block the obturator nerve so that the movement is not there and the surgeon can calmly and take out the entire tumor.
Thank you so much, sir, for answering all the questions. That was the last question for today's session. And at the outset, I would like to thank all the viewers for taking out their valuable time and for being here with at our platform and with us throughout the session. And I would also like to thank you, sir, for taking out your valuable time and for being here and putting so much of effort in understanding our viewers about this particular concept that you have shared today. So thank you so much for this, sir.
Thank you. Thank you so much.
So with all your last comments, sir, we can conclude the session here for today. Until next time.